today for all of us. My name is Santoy Trotter, and I am a manager of our school-based behavioral health programs at UCSF Children's Hospital, Oakland, and part of the Health Equity Action Planning team. And this is session 2, an unprecedented mental health reform landscape in California and what it means for Bay Area children and families. So welcome in, you're in the right place. Thank you for bringing your brains, your hearts, your bodies, and your spirits to this moment to be part of this collective process to think together, right? To face the challenges of this moment and build upon the amazing resources that are available to us all. We want to start by acknowledging the Ramaytush Ohlone peoples and this land that we're on. You know, as we talk about health equity, part of our work in this journey is to dismantle some of the structural oppression, to dismantle the decolonize, right, our minds and decolonize our ways of thinking, and to acknowledge the history, acknowledge peoples. And so we'd like to acknowledge the Ramaytush Ohlone peoples, who are the traditional, the first peoples, the custodians of this land. And we pay our respects to the Ramaytush Ohlone elders, past, present, and future generations who currently call this place home. This land that UCSF sits upon is their home. And we are guests, and we're proud to continue the tradition of coming together and growing as a community. We give thanks to the Ramaytush Ohlone community for their stewardship and their support. And we continue in this moment to strengthen our ties and continue our relationship of mutual understanding and respect. Aho. And so we're here to not only talk about, right, to push forward, to take action towards health equity. And I'm here at Castlemont School-Based Health Clinic, and our AmeriCorps members are hosting a health fair. And I asked Sarah Lee, one of our AmeriCorps members who is going off to become a doctor in about a month, going to med school. And I said, you know, we're talking about health equity today. How would you define that? You know, she has been such a significant contributor to health equity over this past year, as she, you know, one act in coordinating this health fair that's happening right now. And she said, you know, the piece as we kind of all hold, right, this definition of health equity is ensuring access to, that everyone has access, right, to physical wellness, psychological wellness, emotional health, spiritual health, and well-being, right? And that we decrease the barriers to that. And before we move forward, I just invite you to take a moment, right? Emotional, physical, psychological, spiritual health, and well-being. And find a place where you feel that wellness inside yourself. It could be tiny, it could be large, but just notice anywhere inside yourself a place of wellness and well-being. And take a moment to be curious. What are the structures? What are the supports? What are the resources? And how have you had access to that? And that's going to be different for every one of us on this call. But inviting your curiosity with yourself first as we lean out and think about systems and communities and others. We know, right, that health equity is social justice. It's another way of saying health justice. And in order to achieve health equity, we must dismantle those barriers to access, which, and many of those barriers are rooted in structural racism and oppression, right? One of the things I've been thinking about today is, what does health equity look like right now in Buffalo, New York? And can we use our wildest imaginations to think about what would health equity and mental health equity look like right now in Buffalo, New York? In order to achieve health equity and mental health, we must be willing to dismantle these barriers to healthcare, right? And by dismantling these barriers, that we increase the barriers to culturally accountable and responsive mental health care. We learned early on in the pandemic, right, that we have to rethink, relearn how we deliver healthcare to people. And there's an opportunity inside of this, right? Arundhati Roy told us the pandemic is a portal. And inside of this portal, we have an opportunity to look back, right? Last time we talked about Sankofa, important to look back as we move forward. And so we can look back to some of our leaders who have achieved health equity, right? We can look back to the Black Panther Party. We can look back this week, we are celebrating Malcolm X's birthday, Lorraine Hansberry's birthday, Yuri Kochimara's birthday, right? Many people who've worked collectively to organize and dismantle some of the structural barriers to health and well-being. So we are inviting all of us to come together and think about that. You know, and I think one example, right, during the pandemic was even leaning into telehealth, right? That telehealth people could either have access to being able to access mental health therapy in their rooms, it's in their pocket, right? You have your therapist in your pocket. And for some communities, because of phone access, others, there was no way to access that, right? We have to think together. And so now it's our time, right, as health systems to both dismantle these systems of oppression, but also to listen and to lean into all the pathways that have been here all along, right? The answers, you know, we've talked before the room opened up, you know, how do we find the solutions? And what I invite us to think about, the solutions are here, right? What we're actually doing is letting go of the barriers. The pathways are already here. And so we're going to think together around decreasing wait times for mental health, bringing healthcare to children and families where they're at, where they live, where they learn, and where they grow, right? We are the healers. We are the ones that we've been looking for. And not only us, we are going to listen and center the children, families, communities. They have the answers. You heard from our youth speakers last week, or last time we came together, Malia and Tony, and they spoke about, you know, walk and talk therapy, right? That's something that helped me. You heard Tony talk about, I'm worried and afraid of wait lists that I might not get to see a therapist. So we're gonna lift them up. We are grateful for them. And we are grateful for all of you being here with us today. And I'm gonna pass it to Anda.
Thank you so much, Santoy, for grounding us today. And I just want to welcome everyone for taking time in their afternoon and for joining us, and to remind us why we're here. So we're building upon the landscaping and the mental health service map that we detailed in session 1. And in this session, we'll have the opportunity to meet with leaders who are re-envisioning California's systems of care and take a deep dive into unprecedented state reform around behavioral and mental health. And so first, I just want to say I'm personally so grateful to have amazing child advocates as leaders in California, and that we have the opportunity to hear from the principal of the California Children's Trust, Alex Briscoe, and Secretary of Health and Human Services, Mark Ghaly. And we asked them to comment on what healthcare providers need to know in order to maximize their impact in clinical settings within the context of the unprecedented state reform landscape. After that, we'll have the opportunity to hear from a broad range of perspectives from an amazing panel of leaders, with the overall framing question for the panel being, what are specific and concrete ways healthcare team members can optimize their role within the mental health ecosystem, given the new and unprecedented state reform? We'll take a much needed break. And then one of the goals of the series has been to build community and connection, and we'll have that opportunity in our facilitated breakout groups, which are based on health system and include leaders from each system in the breakout group. So now that we have a shared understanding of state policy reform and opportunities for healthcare to optimize care of patients with mental health needs, we now need to better understand on a more granular level what is needed to move toward actionable steps for change. And that's something we keep hearing from our planning committee and from participants, that we really want to know, not just the problem, but what can we do? So we will end with some time to reflect on our breakout group discussions and answer the question, what is one important thing to consider as we structure the third session on June 28th, where we will develop our roadmap and action plan given what we've learned and discussed in sessions 1 and 2. Okay, so for just a quick reminder on the series of the three-part series we have here. Session 1, I'll briefly recap in a minute, where we looked at a critical reflection and a shared path forward. Session 2, we're here today, unprecedented reform in California and what it means for Bay Area children and families. And in session 3, we're going to move from promise to practice and the roadmap for the future. There's a little QR code for registration and the link to our event page. I really want to thank our planning committee. Our members are here. These are just all volunteers who are just very passionate about their work and providing the best care we can for the patients and families we see. And I'm just so grateful for their input through this whole planning. So briefly, a recap of session 1, and I'm just going to quickly say that this first session was a really important step for us to have a common foundation from which we could engage in meaningful discussions in session 2 and 3. So we purposely kind of built time at the beginning so that we could have shared terminology and definitions and a landscape. On the HEAT website, you'll find a recording, and again, there's the QR code. The recording of the first session has chapter tabs that break down the session by like the topics we covered. If you search UCSF Health Equity Action Time, you'll also find it. We heard from 2 brave youth, as Santoy mentioned, who shared their lived experiences, really grounding us in why we're doing this and their challenges navigating the mental health system. We had an overview from Oakland Thrives, hot off the press child and adolescent behavioral health landscape analysis. And then Amy Whittle and Sabrina Fernandez helped us gain shared definitions and terminology by providing an outstanding overview of the basics of the child and adolescent mental health system. We shared a map of what happens when a patient enters one of the UCSF and UCSF affiliated sites from various services, inpatient, outpatient, ER, specialty, primary care, and what happens when a patient enters with mental health needs. And then we heard from Bright Spots, UCSF programs developed to increase the capacity of non-mental health UCSF and ZSFG peds and adolescent providers to support and care for patients with mental health needs. And they're incredible programs. I really am so grateful that they were providing these services and took time to share. And again, you can access the recording on the HEAT webpage and also through the QR code on the slide here. And then we, at the end, asked, what is one goal? And one goal what is one goal you hope UCSF and ZSFG will accomplish in the next 1 to 3 years to better support the mental health and well-being of children, adolescents, and our families? And this is really to try and set us up for the roadmap and action planning. And we took the themes that we heard from the huge Jamboard of responses we got. Thank you for everyone's participation. And while these areas of integrated care coordination system, diversity, equity, inclusion, and specific strategies to support that, the importance of our multi-sector partnerships and engaging and supporting in those, the importance of us as advocacy and really working with our hospitals and health systems to advocate for specific initiatives, and then, of course, capacity building. These are the major themes. I don't think they necessarily might surprise anybody, but I think it validates what a lot of us feel on the ground are the most pressing gaps and opportunities, and lays the groundwork again for us as we think of strategic next steps. So I'm now going to pass this to introduce our next speaker, which is Alex Briscoe. And I'm just so grateful for Alex's partnership over many, many years with us as we rethink and reimagine our systems. And we asked him to answer the question, what do healthcare providers need to know in order to maximize their impact in clinical settings within the unprecedented state reform landscape? Alex Briscoe, as many of you know, is a principal at the California Children's Trust, and his work has helped design the nexus of public health and public education. He's designed and administered a number of mental health and physical health programs and services in child serving systems, including home visiting programs, programs for medically fragile children, and clinical and developmental programs in child welfare, juvenile justice, and early childhood settings. Alex is a mental health practitioner specializing in adolescent services and youth development, and he's specialized in Medicaid policy and administration, emergency medical services, youth voice and crisis counseling, and safety net design and administration. And he's been such a critical partner. Alex, I'm so grateful for you for sharing your wisdom with us.
Thank you.
Turn it to you.
Yeah, I'll pull up the slides here. A mentor of mine once said, we're all better when we act on the exhale. So I'm going to try to remember that for a second. Because I have some stuff I want to get through to answer Anda's question. Because if we don't frame it right, we're going to solve the wrong problem. So I'm going to breathe out. And I'm going to try to move quickly through some context setting and some numbers and data, which basically are meant to leave you with the details of what you know to be true about young people. And then I'm going to try to describe and hold for you in 2 minutes or less the map of Medicaid in California. Then I'll try to specify specifically what's happening, what changes are occurring, because if you ever were a kid or you work with kids or you have one, you're worried about young people, and you should be. And it's not them, it's us. We've built a toxic culture, and we have to now arm young people how to survive and thrive in it. And I'm going to detail at the very end on my last slide a set of 9 things you can do right now as a health system to take advantage of what's before you, but it will require you grow and change, and it will be uncomfortable. So here we go. As you know, there was a crisis before the pandemic. We saw a doubling of inpatient admissions, an increase in pediatric bed days, while the rest of the healthcare system saw significant declines. Young people told us in the California Healthy Kids Survey, and I think the clinical term is we suck. We are the nation's largest Medicaid program for children, and by any standard measure, among the worst for kids. And the pandemic poured gasoline on that fire of a crisis. We are now in whatever you call that. And level 1 pediatric trauma centers, including Rady Children's and Benioff Children's Oakland, have seen just unprecedented levels of admissions for self-injury and self-harm. And if you don't disaggregate this data by race and class, you're missing the point. So the architecture of solution has to be with a analysis of the challenges that young people face at the nexus of race and poverty. Making healing-centered systems can't just be about tweaking programs, though we're going to talk about tweaking. And it can't just be about the technocratic fixes of Medicaid benefit design and provider class expansion. It actually requires a fundamental reform of what we're trying to do and how we do it. And the medical model cannot and will not and never will be the answer. I have literally built, I don't even know how many, hundreds of millions of dollars of mental health services under the NPI that I used to hold. And very small percentage of the young people I served actually met the diagnostic criteria that was required for me to get paid. 75% of mental illness manifests at the time that young people use the healthcare system the least. There's also the cultural challenges that Dr. Barbara Staggers taught me and many others, that if you want to kill volumes, put police or parents in the waiting room. There aren't enough providers. Even if we wanted to give everybody a therapist, which we don't, there wouldn't be enough anyway. And diagnosis-driven models are only appropriate for a small number of young people. Nadine and her work and others have really begun to crack the code of the impact of race and class on the social and emotional health of children. We don't have a common framework. Our systems are fragmented. Wow, I hope you're getting a little depressed, because this is the clarification of the context that we're solving for. And our definition of medical necessity, what qualifies you for care, is just broken. In fact, it's racist. At its heart, it's tied to pathologizing of low-income communities of color, and we must directly and forcibly confront that in any solution. So why is Medicaid so important? Because it is. It's pretty much everything to the challenges, to the payment system facing young people. 60% of California's 10 million children, in fact, it's a greater number than that now, are covered by Medi-Cal and eligible for the EPSDT benefit. This represents a 33% increase over the last 5 years. That's less than 5% of those 6 million children are getting access to any care at all. That means touch the system one time. And only 3% are in ongoing care as measured by 5 or more visits in a year. This is nonsensical from every potential perspective. But Medicaid itself is pretty simple. So here we go. We're going to teach you Medicaid, and it should leave you hopeful. Every Medicaid expenditure is the same construct. It's part state and part federal. There's fancy words for this, but just think of Medicaid like a pot of gold sitting in DC. You put up $1 to get $1. California taxes itself at the second highest level of any state in the nation and gets the 39th most federal matching funds. So part of our challenge is just to be better at the math. To generate the resources we need to transform our system, we have to be better at this equation. There are fancy names for these terms. The non-federal dollar is called a certified public expenditure. The federal dollar is called federal financial participation. But just hold in your mind that all of Medicaid, every time Medicaid makes a payment, it has a non-federal part and a federal part. So seemingly so simple, we should be good at it, right? But we're not. To track the sort of architecture of our problem, you have to see how those federal dollars flow through the state and show up in the lives of children and families. And so this is the architecture or the map of Medicaid in California. Health plans in every county, there's a different economy. In San Francisco, you are a 2-plan county, Anthem and the San Francisco Health Plan. In Alameda County, you're a 2-plan shifting to a 1-plan county, Alameda Alliance and Anthem. And these are the primary actors in the Medicaid universe and becoming increasingly so. Because the health system you work in has the unique benefit of being federally qualified, this payer is a particular interest to you, in particular what we call the non-specialty mental health benefit, a benefit that has only existed since 2015. So I'm going to say this one again, it's really important. The managed care plans didn't even have a mental health benefit until 2015, when we had to add that benefit in order to qualify for the Affordable Care Act to offer the 10 essential benefits. But for Santoy and others who work in the system now, you also work very directly with your county mental health plan, what is sometimes referred to as the carve-out or the 1915B county mental health plan. The little letters underneath describe the payment mechanism they live in, so you can ignore those. But county mental health plans get paid differently than managed care plans. There's school districts, there's community health centers, there's public health departments, there's the public hospital and the regional center. Let's all breathe out for a second. When everyone is responsible, nobody is. The architecture of our challenge isn't that we don't care enough, isn't that we don't believe that young people need to survive and thrive. It's that we have diffused accountability for a federal entitlement across so many systems that it is almost impossible now for systems like yours to navigate them at scale. What this has led to is we rank in the bottom third nationally in spending per beneficiary. Kids are 42% of all enrollees, but only 14% of all expenditures, et cetera, et cetera, et cetera. So if you're not depressed, you're not listening. This has brought us to a moment of reform and change. Extraordinary state leadership, a governor who has made an affirmative commitment to the health and welfare of children, an awakening of the impact of race and class. Whatever your feelings are about screening in your primary care clinic for adversity, there is no doubt that Nadine Burke-Harris's work has helped transform the conversation about what impacts young people and how we should respond. At the California Children's Trust, we were formed 5 years ago to lead a statewide effort to reimagine children's mental health. We're coalition supported with more than 400 organizations, and we focus on equity and justice, including the acknowledgement of how systems like the one you work in, out of even the best of intentions, have pathologized and harmed low-income children of color. 75% of children in the Medicaid program are children of color. To help hold the reforms I'm about to name, to give you a framework to understand them, we say they all have to be focused on equity and justice. This means that transformed systems are anchored in new principles of anti-poverty and anti-racism. They're informed by relationships to beneficiaries. They have designed-in methods of accountability. And the way we distill this, or how we say the essential strategy of equity is that we must shift agency, defined by who does the work, and power, defined by who gets paid to do it. So that means less empty vessels, less pathologizing, more co-construction. The future of children's mental health looks a lot more like mutual aid, a lot more like peer-to-peer programs, a lot more like social models, clinically articulated but not clinically intermediated. Payment reform is coming to all of our systems. So in this framework for solutions, if you accept that we're shifting agency and power, we also have to spend a lot more money and spend it differently. There are essential components of the reforms that are coming that are going to mean the way you get paid as a health system is going to shift. Not only who pays you, but how you get paid. We must expand access and participation, not only serve more people, but move away from a diagnosis-driven identified a patient approach and center the impact of racism and poverty formally, not as a narrative, but as a criteria for access. This also includes expanding the eligible provider classes. In the last year, California has made an unprecedented commitment to shifting who can do the work, agency, and power by formally incorporating peers, CHWs, doulas, and behavioral health coaches into the Medicaid line of work. You will see I will invite you as a health system to reimagine who you hire and how the clinicians you work with currently work with expanded provider classes. One thing to ground this work in UCSF's proud history, Dr. Thomas Bodenheimer at UCSF identified in the 80s and 90s the reality that if we were going to assign everyone to a primary care home, there was never going to be enough primary care physicians. And he and many other physicians led the movement to team-based primary care. Behavioral health is headed the same way, to an expansion of who does the work and who gets paid to do it. Eliminating efficiencies, meaning standardized documentation forms, creating a single credentialing process. The idea that our very limited provider class has to credential itself across two distinct systems, across different payment methodologies and two contractual burdens is nonsensical. This issue must get solved. There has to be consistent guidance county to county. For those of you who work across counties know that feudal California has a uniquely distinct culture of practice in every county because there's a lack of consistency. And our healing-focused models must be consistent across not only payment systems in Medicaid, but the child-serving systems that they work with. So this is our framework for solutions. We have to shift agency and power. We have to increase our spending and how we spend it. We have to expand who is eligible and who does the work. And we have to increase transparency and accountability. So let's talk about what this has brought us to. This is one attempt to eat the world of an unprecedented reform landscape. And I will suggest that one way to look at this is to break it up into these three boxes, but there are other ways to do it. This is just one attempt to try to organize this landscape. Some things have happened. The pandemic has exacerbated everybody's understanding of the social and emotional health needs of children. And to be frank, money's falling out of rich people's pockets at unprecedented levels. Meaning we are seeing one-time expenditures that we've never seen before in our state. It is up to us to take them, to use them to leverage long-term change. One important example is the Youth Behavioral Health Initiative. $4.4 billion, including the school-based behavioral health incentive program, one-time dollars to get health plans to start working with schools, but permanent investments as well, including the dyadic benefit that was designed and created right there at the Children's Health Center with Dr. Kate Margolis, Amy Whittle, Anda, and everybody else. That's a new benefit that's going to allow caregivers to get mental health services during the time that they bring their babies into the well child visits. The governor's budget also makes unprecedented commitments, and not just in the healthcare sector, but also in the child welfare sector, and particularly in the education sector. And then finally, the new transformation of our Medi-Cal system under CalAIM, which is code for both the negotiation of the two federal waivers that define our system, as well as the federal dollars that are funding through ESSER. So let me try to wrap here with a call to action and then some specific steps that you can take. As both clinicians, providers, and systems, you need to know this map. If you're not tracking the one-time investments, including $389 million coming to schools through health plans, $550 million again coming to schools beginning in December, practice transformation grants coming, evidence-based practice grants coming, as a health system, you need to know this map to seek the resources necessary to transform your practice. Our call to action at the Trust has been remove diagnosis. There should be no reason you have to have a diagnosis in Medicaid. You don't have to have a diagnosis to get measles, mumps, or rubella vaccination. It's the same benefit. We have to capture Medicaid dollars more effectively. We have to center schools. We have to expand the eligible provider class. We have to focus on benefit design and construction so we can pay for the things that clinicians say they want, particularly integrated behavioral health in pediatric practice and family care settings. We have to focus care coordination as a way to bring culturally concordant community-based organizations into our system. I'll follow up with that in a second. And we have to develop social models, cascading mentorship and mutual aid strategies, meaning clinic-initiated services that are enhanced, supported, and deepened in relationship between and among beneficiaries in their community. So let me end with what you can do as a health system to both respond to our call to action at the Trust, but also to hold the details of the unprecedented reform landscape that is before you. It's important to understand that the landscape of medical necessity has fundamentally changed as of January 1st. As far as I know, we are the only state in the nation that qualifies you for mental health services and supports if you have an experience of racism. The new family therapy benefit qualifies you for mental health services if you've had an experience of racism, if you are living in housing instability, or if you've had any other of the 10 adverse child experiences. That is an incredible and a fundamental shift of what qualifies you for care, but it means nothing if you don't use it as clinicians. You need to know what Z65.9 is. If you don't know what Z65.9 is, it's really, really important to learn it. It is the Z code you now use to qualify Medi-Cal beneficiaries under the age of 21 for access to mental health support without a diagnosis. So understanding the changing medical necessity landscape is really important for clinicians and systems to capture the promise of the reform landscape. There's also been a very important change in the specialty mental health system in the county side, where system-involved youth, young people who are either in the child welfare system or the juvenile justice system, are automatically eligible for service. So if you've ever referred a kid to your county mental health system and been told, oh, they don't meet medical necessity, that is no longer an allowed response from a county for a kid who's in juvenile justice and child welfare. You must understand, and I feel like I'm saying must, so I don't mean to wag my finger. We together need to understand the growing role of managed care organizations as the center of the Medicaid universe. And we could discuss up and down, left and right, whether this is the right way to go. Secretary Ghaly is going to join us shortly. I can say that as an advocate sitting on the outside, I can say it's going to be really, really hard, but I'm not sure there's any other choice. Managed care organizations are being given huge new responsibilities and centered in this post-reform landscape. And I think it's important for providers, particularly safety net providers, who have historically worked with departments of public health, historically required on their FQHC status, historically partnered with county mental health systems, to refocus their energy on contract and reimbursement negotiation in the managed care space. The managed care plans are being given a huge responsibility. They can't do it without their providers. And you have this unique opportunity to account for the biggest challenge that you face there, which is the rates are too low. Because of your FQHC status, you can wrap up these low rates to rates that make sense. And it is essential, super important for health systems like yours to partner with MCOs to pull in those extra state and federal dollars that your FQHC status allows for. Let me be more direct. To my friends and colleagues like Santoy and others who work in FQHCs who've historically paid their bills with specialty mental health contracts, I encourage you to look at opportunities to expand your partnership with the non-specialty system and bill services to the health plans that you can wrap up to PPS. Learning about this still bifurcated system and developing very specific requests. I heard once from another mentor that the heart of integrity is specificity. The payment systems need to be asked what to do because they don't know. If they knew how to treat racism and poverty, I promise you they would have done it. You have a unique lens, and I think sometimes the power differential between payer and provider needs to be re-examined and flipped. The payers are just payers, they can't do it without you. So I think looking at your both specialty mental health service contracts, your county contracts, and your MCO negotiations, and being more specific. Ask for non-specialty mental health and care coordination contracts bundled together. Ask for higher rates or differential payments or quality or incentive payments for specific performance outcomes that you and the plan can agree are important. Bill, Z65.9, I feel like we all need a t-shirt. So if I spontaneously combust and you take nothing else from what I say today, I hope you can understand the new benefit landscape, in particular the new family therapy benefit and the new dyadic benefit. They're essential to hold and understand because they are examples of the state trying to solve these issues at scale. And I can't tell you, it does bring tears to my eyes and my nose burns. We have spent 20 some years, those of us in safety net land, pounding on the state's door, begging for attention for the plight of children in the Medicaid program. And we have repeatedly been turned away. That is not the situation we're in, and these benefit design changes represent a unique opportunity for us to practice different. We are beginning to bring into alignment the reimbursement practice with the clinical practice, and that's super important. Centering schools as healing and anti-racist centers of support are the only solution for you. You cannot get there by yourself, meaning more formal articulation to the San Francisco Wellness Centers, to the Center for Healthy Schools and Communities in Alameda County. You have unique footprints of school-based mental health supports that need to be more clearly, clinically, and administratively articulated to your clinical settings. These resources are growing in schools. Somewhere between $6 and $10 billion will be spent in schools over the next 3 years to expand mental health supports. Your ability to link and connect and broker access to those services and supports is really important to the future of healthcare systems work in mental health. Hire from an expanded provider class. I hope, please, I will say that I've been involved in a couple demonstration projects that have been difficult with UCSF because of the culture of hiring practices and the lack of understanding of the expanded provider classes, and frankly, a little bit of the protective nature of institutions from partnership with community-based organizations. I would invite particularly administrative leaders to be creative and courageous in breaking down some of the barriers of the healthcare industry that imprisons low-income communities in pathology and denies access to the reimbursement streams that you control. Partnering and co-locating community-based organizations in your clinics is super important, and expanding your provider classes and team-based models is a really new and critical opportunity to addressing children's mental health. Focusing on the care coordination obligation that health plans have is sort of one of the untapped opportunities. Currently, under the boilerplate contract of the managed care organizations in both San Francisco and California, in Alameda, is an obligation to provide care coordination services to children in Medicaid. This is frankly a phantom benefit. It's a requirement that is neither enforced nor does it exist. We will drop into the chat a link to the actual citations in the contracts. They can be the beginning of a negotiation between you and your managed care plans. The managed care plans, if they make those investments, will have their rates raised within 2 years through something called the look back. So it's not like trying to get money out of someone who doesn't want to pay. If health plans can front the money, they will be made whole in something called the look back. So it's the type of negotiation, again, between payer and provider that can be mutually beneficial. Finally, you have to know the one-time landscape. As I mentioned, money is falling out of rich people's pockets at unprecedented levels. Mental Health Services Act revenue is going to grow from $3 billion to $3.7 billion in 1 year. That is a 35% increase in income tax for millionaires in California. Clinical systems like UCSF should be directly approaching county mental health plans about what they intend to do with those resources, lest they get recouped by the state. And you should be tracking the individual buckets of funding that are coming through the Youth Behavioral Health Initiative. Specifically, and I'll point to the 3 big ones again. The Equity and Practice Transformation Grants. Pallav Barbaria is an extraordinary leader at DHCS. The work she's doing with the Children's Medicaid Quality Design is a really important work to know and understand about. The evidence-based practice transformation and the school-based behavioral health. Evidence-based practices and school behavioral health. Those are the 3 buckets of $300 to $500 million that will be out in the next 12 to 18 months. Finally, I'd like to make a call out to 2 specific projects that are happening at UCSF that I think are really important. CAP is a pediatric primary care consult service, and I think UCSF as an actor to support other clinical practices and do system building is a really important and opportunity. And also the Dyadic TA Center being built by Dr. Kate Margolis, which is already doing projects in Los Angeles and Santa Clara, in the San Francisco Health Network and in Marin. So I think these are two system level interventions and things that UCSF can do to grow and engage. So with that, I will stop. Thank you. I know I talk fast. It's really great to see so many beloved people doing such important work. And I'll pause. Thank you.
Alex, thank you so much. I don't know if others are like me, but I'm sure I will be listening to that over and over again so I can absorb all of the wisdom you shared and the opportunities we have and really digest. So thank you. And we'll have a opportunity to engage with Mark and Alex in the panel along with other experts who are here with us today. We're a little bit ahead of schedule, but that actually was our intent because we know that the panel discussion is really where the money is and that people will want to engage there. So we were trying to build in as much time as possible. Mark Ghaly, I just want to make sure you're here. And also, I think, like me, he was having a little trouble with his internet and stuff. So hopefully he will, well, we will all figure that out. So he needs no introduction, the Secretary of California Health and Human Services, Dr. Mark Ghaly. And again, we also asked him to comment on what do healthcare providers need to know in order to maximize their impact in clinical settings within the unprecedented state reform landscape. And as many of you may know, Dr. Ghaly was appointed Secretary of the California Health and Human Services Agency in early 2019 by Governor Gavin Newsom. And in serving California, he's had the privilege of working with partners across sectors and disciplines to improve the lives and life chances of all Californians. He's a primary care pediatrician who continues to use his clinical and community experiences working in California's healthcare safety net system to inform a whole person, whole community approach to integrating services so they are equity anchored and person-centered for all, but especially the most vulnerable Californians. Many of you may know he's a graduate of the UCSF residency program, so he has some home bases here in the Bay Area, and that he was also medical director of our San Francisco DPH Southeast Health Clinic, Health Center, excuse me. So again, just so grateful for all the expertise and leadership we have in this state. If Mark has not been able to join yet, we actually could take some time because I'm sure that people have questions for you, Alex, if you're willing to answer them now, given all the information you shared with us. So maybe we'll do that.
Yeah, I will quickly just, Nikki, thank you so much for those kind words. And I will, in a second, I'll find it on the internet. The National Health Employment Law Program, NHELP, has a really nice set of cheat sheets on the new definitions of medical necessity, both in the family therapy benefit and in the 1915B waiver. And just maybe, and I think those of you who know me know I can geek out on Medicaid. I actually think it's kind of sexy, but nobody else does. But there's these, basically in Medicaid, you write a state plan that says, this is how I'm going to administer Medicaid. But then, of course, the state plan doesn't cover everything. And then so you write a set of things called waivers, which capture other parts of the program that the state plan doesn't. The 1915B waiver is the waiver that covers the specialty mental health system, the county mental health system. So when you hear me say 1915B or specialty mental health, I'm referring to the county mental health system. And there has been a long battle over the requirement for diagnosis in both systems. That has been won. That's really what I'm trying to say. And the definition of the 1915B medical necessity that just got approved in January 1 automatically qualifies any child in child welfare and juvenile justice for services in the specialty system. It's really important. It's not a clear path because it's unclear to me how we're going to pay for this expanded eligibility, but it's important to know. On the family therapy benefit side, and we'll try to post in the chat both a press piece, but also the actual provider manual. The definition of medical necessity was approved actually about a year ago. And page 4 of the provider manual details the 12 eligibility criteria, which are the 10 ACEs plus housing instability and an experience of racism. And the code you use, the diagnostic code, is this Z65.9, and then a set of CPT codes, which you will recognize as the traditional CPT codes. But Nikki, to your question in the chat, I will find the actual NHELP citations. They're like one-pagers on the internet, and make sure you get a copy of them. We'll post them in the chat.
So there's a really great question that I'm going to toss out to you that's in the chat that I think many of us who are on the front lines feel every day. And so the question's from Peggy, and it's for those of us who try to help families navigate access to county mental health resources. Basically, is there a script to advise parents on this important change? What do we tell families who are trying to navigate this crazy system?
Oh my goodness. Well, and what has got to be what the worst morbid joke of all time is, lawyers are the new social workers. So what I would suggest to any parent trying to navigate the system is, first and foremost, believe in the entitlement. No is not an acceptable answer. In fact, for the briefest of history lessons, children in Medicaid are different than adults. In 1967, the military sponsored an amendment to the Social Security Act. And the military did it because they had drafted 500,000 poor men into the Vietnam War draft and rejected half of them for unfitness to serve. So literally, the military was so freaked out about the health of poor people that they changed the entire criteria for children in Medicaid. You know it as EPSDT. And what they basically said is, you don't have to be sick to get care. In fact, the EPSDT entitlement reads that the state must provide all services to children regardless of whether they're listed in the state plan or not. But it also fundamentally shifted the definition of medical necessity. You heard me mention, you don't have to have measles to get an MMR shot, right? What Medicaid did for children was said, children, by status of them being a child and poor, get access to stuff to help them grow and thrive. In fact, they get access to everything they need. So back to the parent question is, don't take no for an answer. First, when told no, both the non-specialty mental health system has specific provision for self-referral, meaning you can, if you identify a therapist that you want, that system must pay for them. So advocate, don't take no for an answer. On the specialty mental health system, historically, the county has been able to say to you, and when I say the county, and I don't mean to demean or diminish anybody, that was me for many years, saying no. It hurt my heart and my soul. But historically has been able to say, you're not sick enough. You don't meet one of the 12 diagnostic criteria. Many people on this call have manipulated that, adjustment disorder not otherwise specified, things like that, all inappropriate and frankly fraudulent ways to make sure that young people got what they needed. It is really important that the specialty mental health system now acknowledges that as of January 1, they are obligated to serve any child with juvenile justice or child welfare system involvement by definition under the new 1915B waiver. And I'll provide the third piece of counsel, which I think anyone who's worked with kids, system and the non-specialty system, don't take no for an answer. And then when all else fails, get a lawyer and an IEP. I wish I didn't have to say that, but all of us who've done it know that the placement of last resort before you put a kid in juvenile hall is the special education system, and that an IEP is a legally binding contract between the school district and that family. It is an incredible ball and chain around our public education system. 775,000 kids cost our system $15 billion a year. The state pays 3 of it, the feds pay 2 of it, local systems absorb the rest. It's preposterous. But if I was a parent, I would say know the managed care plan your kid is in. Don't take no for an answer. Pound the door of your county mental health plan. If you know of a clinician that you believe, who's willing to fight the battle with you, the health plan has to pay them in or out of network. And then finally, if all else fails, get an IEP and a lawyer. Very
there's
sad.
a follow-up to that question too, which is, does this billing with this diagnostic code Z69.5, does that apply to private insurances or PPOs?
So no, it only applies, well, Kate reminds me, a very good point. We have equated EPSDT with the specialty mental health system for too long in California. That is not what it is. EPSDT is a benefit that covers all children in Medicaid, physical behavioral health. The bifurcation of it into the county mental health system is a total fabrication of California's carve-out. So when you use the term EPSDT, know that it applies to everything from immunizations. It covers care coordination and managed care plans. It is the broad umbrella of that unique status that children enjoy. Yeah, I'm sorry, Dan, I lost my train of thought. What was your question again?
It's all right, you answered it. The simple answer is no, that it doesn't apply to private insurance. So I feel as if we could continue with this conversation, and that we need to have like a 5-day seminar on all the Medi-Cal billing and reform. I really thank you for letting me switch up our plans and ask you questions. I do think Secretary Ghaly is here, and so we're going to pass over the platform to him. Thank you, everyone.
Hey, all. Can you hear me okay?
Yes, and I introduced you and sent you all these accolades earlier, so you missed them, but I can always repeat them to you later.
No, I'm glad I missed them. I prefer not to hear all of those, but I am sad to have missed Alex's talk, because I always learn when he's at the mic. Let me just start by saying thank you for including me. It's always fun to be back with my old crew at UCSF, and part of the work that you all are doing. And I'm excited that these are the questions that you all are asking and struggling with and wanting to make a difference, both in the moment for the people in front of you, your patients, their families, but also system-wide. I think, through a lot of what Alex has pushed and a number of other people in the next panel, what they pushed, I think we're really at a fun time for California. The backdrop of, well, can't you, well, shouldn't you, why don't you, is starting to turn into, well, we can and we are, even if imperfectly, trying to do some things that we haven't done before. And that is because of pressure and calling it out from folks like Alex and Tom and others, many of you. The fact that we have a governor who cares deeply about kids and behavioral health, and understands the social drivers, understands the investments early. And then I think we also are gifted with resources at the moment to make the kind of investments. And certainly, a lot of my job was not expected. And I think part of that was the last 2 years of real opportunity and being able to seize those with the budget. So today, I'm going to try to do 3 quick things, share with you how we plan to build on some of what Alex talked about and reimagine this behavioral health system for children, youth, and families, introduce some of the components of the Children, Youth Behavioral Health Initiative that was sort of unveiled last May and started to come together over the summer and is kind of active right now. And then share a little bit about some new investments that were recently proposed just about 2 weeks ago in what we call the May revised budget, which, as many of you who know the budget process know, that California goes out in January with a governor proposed budget, and these are all the ideas and plans for what we're going to do as a state. And then typically in May, they revise the budget based on updated financial forecasts from the reality of what's happened in the markets and what's happened on tax returns in California. That usually doesn't become clear until April. And then oftentimes it's just small tweaks here or there, but the last 2 years, they have been enormous dollar amounts that really kind of create a whole nother set of new investments. So I'm going to try to do all 3 of those things pretty quickly, because I know the next panel will really be meaty and fun for all of us to participate in. So next slide, please. Okay, so here are just a few points. A lot of this either Alex showed or you all already know, but I'm not going to go into the left side of this. COVID-19 has compounded behavioral health needs of kids. You all know it more real than I do in your day-to-day practices, and just the level of our ability to get the services to young people is just not there. Like, we don't have the capacity at the moment using the sort of same systems, programs, pathways that we have had existing to really meet this kind of need. And not only are all of us in the field recognizing this, but I think Californians at large have recognized this. And despite some pretty incredible efforts over the last handful of years, we find ourselves in deeper and deeper holes. We're starting to see efforts like, just the suicide numbers are not only going up, they're affecting different populations that we didn't typically see affected. It's not just about social pressures and some of the other typical drivers of suicide. You are seeing a lot more related to the uncertainty of the pandemic and economic inequality, et cetera, just really coming together and creating conditions that young people don't have the tools themselves to handle, and we don't have the tools as caregivers and providers to really serve them. And we also are seeing this, and I always find it important to mention that even though conditions throughout our state are in general getting deeper and harder for young people, those who are system involved in either the juvenile justice system, the child welfare system, their plight is getting even tougher, because not only are the rules more complex than they've ever been on identifying and getting placements and services in the right time of the right variety, but just the need is growing, and the workforce and the places to do that work are shrinking. So this we're all pretty keenly aware of, but the data, it's too much to remind us of some of these data points. Next slide. What we also know that when we deliver behavioral health services integrated in primary care, that you see improvements. That's not a surprise to many of you. I know it's a 2014 pediatrics publication, but I still think this rings true. We also know that when young people get additional resources and help, that it makes a difference, and it increases resilience and ability around self-advocacy, self-efficacy in communities, skills that I know as primary care pediatric folks, as people thinking about childhood development, we recognize that anything that supports that resilience throughout that lifespan is key. And then lastly, we often overlook that the efforts that we make to ensure that young people struggling, especially with serious mental illness, when they receive the kind of care and support that they need, it means just a whole different story for their long-term life outcomes, their long-term lifetime earnings. And so the return on investment in investing in young people is not something I need to remind all of you about, but it's still important to keep in mind when we think about the kind of investments I'm going to talk through. So next slide. So many of you have heard me or others talk about the Children and Youth Behavioral Health Initiative. One day, how this all sort of came together and sort of became what we're working on is worth a story in and of itself. But the goal is to reimagine the way behavioral health support is provided to kids across the state, aligning the systems that support behavioral health, both within the Medicaid healthcare space, but also surrounding youth as well. To use a phrase that Melissa Stafford Jones often talks through, thinking about it as an ecosystem that fosters social and emotional well-being and addresses those behavioral health challenges facing kids. And we really seek to take a whole systems approach, again, not just focused on parts of the healthcare delivery system, but the entirety of the health continuum plus the community continuum, to really think of something that's child and youth centered and anchored and focused in equity. Next slide. So again, I'm just going to focus on the right, really focused on advancing equity, trying through the design process to make sure that this is for youth by youth. So a lot of youth engagement, a lot of effort being made to draw in youth from across not just the diverse populations of California, but the diverse geography of California, whether that's Central Valley, Southern, Bay Area, Northern Cal, trying to get it all really. And it's funny, sometimes I say, well, why are we calling out centering around children and youth? That's so obvious. But sometimes, as Alex's presentation maybe didn't directly say, but we've often centered these systems around the finances, around the bureaucracy and the billing, and not what the kids and youth actually need. Goal is to empower families and communities. So not forgetting that often young people depend on their families, but their communities as well. Making sure, and I think all of you know this well, right time, right place can't be overstated. Finding the right service weeks from now means missing a chance. Finding the wrong service now means getting somebody started down the wrong path. And then, as always, focusing on reducing stigma, focusing on being free of stigma. How do we start to normalize and talk about behavioral health conditions in the same way we talk about the dentist or the primary care visit? I often think that, there's usually kids don't feel ashamed or worried about standing up and reminding their teacher they have to go to the dentist or the doctor, but few kids will feel comfortable because of the environment we've built around them, around behavioral health and wellness, to stand up and say, I've got to leave for behavioral health type appointment. So how do we begin to really use the efforts of the Children Youth Behavioral Health Initiative and $4.4 billion of investment to make a dent in this? I'm going to show you how on the next slide some of that's supposed to come together. So if we could advance it, please. So again, this slide reminds you, focus on the entire continuum of care, but I think more appropriately on the community continuum as well. It's not just about those places that provide care. It's often the places that interact and support young people. That could mean the community center, the school, faith-based institutions. Yes, they're providing care as well, but different than, I think, the healthcare services we often think about. We want to increase system capacity. I mentioned up top, we'll keep on mentioning that we don't have enough capacity. I think we need different kinds of capacity as well. So it's not just let's build more of what we already have. It's trying to build differently as well. But no doubt we need to increase capacity, both physical bricks and mortar. That's around communications, around assessments, around the IT tools that can help us, and of course, around the workforce. Making sure that we're centering around the needs of youth, already addressed that in the stigma piece, and making sure that we're catalyzing system redesign within and across sectors. So this means not just in Medicaid, but the last EPSDT comment and the fact that that is not for kids with commercial coverage necessarily, but you'll see one of our efforts is to try to expand what we're doing for young people through Medicaid and making it statewide, all kids, regardless of payer. And that's one of the principles of the Children Youth Behavioral Health Initiative that I think is unique, often under-addressed, but a real amazing opportunity to say, with our health plan partners, whatever we're providing and paying for through Medicaid through this initiative, we're expecting and working on creating the tools that allow you to provide the same services for young people in commercial or private insurance. Next slide. So this is, I know, a busy slide, but I'm going to focus really on the blue boxes. Really 4 major categories around the Children Youth Behavioral Health Initiative and our kind of work streams. One is focused on workforce training and capacity. This includes some things I'll get into specifics around behavioral health workforce. As I said, not just focusing on paying for more of what we already have, but creating some new types of positions, states really promoting and pushing forward a whole effort around community health workers. But we have a whole notion, and I credit Tom Insel and some others who I'm sure many of you know, around really pushing a behavioral health coach model. Certainly somebody who receives a sufficient, significant amount of training, but is really recruited for their interest in connecting, supporting young people in this case around coaching through tough situations, through typical or even atypical behavioral health and wellness challenges that they face in the context of other support. So this big workforce being created that we hope is going to be widely available and supportive. I hope supportive of many of the patients that you all take care of at UCSF and beyond in San Francisco. The Behavioral Health Virtual Services Platform is one of the anchors of the whole initiative. This is kind of the front door. The vision is to create something that is a virtual available tool for all California young people and their families to not just be assessed for needs, but also to have access to services that they may just want and desire, as well as tools to help support common challenges. We're trying to build this out. It will also have a e-consult component that we will make widely available to providers, both in the Medicaid and the non-Medicaid space, to allow primary care and other providers who are not necessarily behavioral health providers, but meet young people with behavioral health needs to both get asynchronous advice, but also working to see if that can be live, almost like a behavioral health warm line for youth behavioral health services for the state. So a lot more to say in this space. I'm happy to take some questions at the end, but I can lose our entire time focusing on any one of these areas. The behavioral health ecosystem infrastructure money or efforts there, this is around many. There's some incentive dollars that are meant to support health plans or providers working with schools, as an example, implementing evidence-based and community supported practices. The sort of top right behavioral health continuum infrastructure program is something not separate and apart from the Children Youth Behavioral Health Initiative. There's over 400, I think it's almost 500, maybe $470 million of funding to help build new brick and mortar facilities to support children and youth behavioral health programs. These could be outpatient, community-based programs or additional acute beds if needed. So I hope UCSF and the UC system looks at that as an opportunity. Those dollars are being made available this summer. Another area, I think all of you know, many of you know, you should know, dyadic services. Alex, thank you for your advocacy and work and demonstrating the evidence, the work with UCSF and others to really bring it on our radar. And now an enhanced Medi-Cal benefit that is funded. And as Alex and I talked about at one point, even though it has a dollar figure attached to the budget, because it's a benefit and a universal benefit, the more it's required and needed, California would certainly support whatever is needed and medically necessary in this area. I alluded to this, but this to me is one of the more exciting parts of the initiative, this idea that we're creating an all-payer fee schedule for school-linked behavioral health services. So often Medicaid, through its different schemes, will find a way to support school-based or school-linked services. I like to talk about school-linked rather than just school-based, because school-based sounds like it all has to happen in a room on campus, but it could certainly be linked to a school. Not every school has the luxury of space or staff or time to use their space. So looking to expand that school-based concept to school-linked. But the concept here is that our commercial health plans would agree to a fee schedule and pay for those same services, just like you would receive under in Medicaid. So I think this is a pretty groundbreaking move on our part, in my opinion. One I hope to see not just be successful here, but my hope is that we'll take it and apply it elsewhere. And then we talked about stigma. We talked about the need for education and funding, both through the ACEs Aware campaign that I think you all are both intimately aware of, but also some significant funding going to the Department of Public Health at the state level to support additional work in this space. Next slide. This is an eye chart. I know it. Yes, people can have the slides, but I just wanted to talk about a few of these things in more specific. We are working to make sure, I'll just pick a couple of them. The second meaningful row, pediatric primary care and other healthcare providers, providing opportunities for primary care and other healthcare providers to access culturally proficient education and training on behavioral health and suicide prevention. There's specific funding in the initiative for that part of the work. I'm going to get into the behavioral health workforce investments in a second. We'll talk more about Cal Hope in a moment as well. I mentioned already, just moving down this list, both the evidence-based and community-defined practices. This is not a small bucket of funding. It's almost $400 million to go into scaling evidence-based practices that are already in parts of the state, and then also identifying new community-defined practices to spread across the state. So stay tuned on how UC can be involved there. The behavioral health virtual platform I mentioned as sort of an anchor to a lot of what we're doing. And then some of these other efforts around school partnerships, both through incentive payments through the Medi-Cal managed care plans, but also through MHSA funding and schooling partnerships. The other parts of this I've either touched on or we don't have enough time to go through, but I'm happy to answer questions later on this if there are any. But the point of this is that not only is the Children Youth Behavioral Health Initiative have many components, the part you don't see here, and it should, if I was as complete as I would like, is you'd see how this initiative is connected to what we talk a lot about in Cal-AIM. I expect many of you have been part of those Cal-AIM conversations. There are a number of overlapping pieces, not just on sort of integrating behavioral health into our practice design, simplifying how it comes together with physical health components, but certainly so many of the focus both of Cal-AIM and of our managed care re-procurement process, which is out on the streets for all commercial plans. But the whole idea of that new procurement for Medicaid managed care programs in the state is to raise the bar. And one of the bars that is getting raised up pretty significantly, maybe not as much as we all want or like or expect, but certainly significant to where we are issues around Medicaid managed care's partnerships with places like schools and health providers, and a focus on behavioral health specifically for kids. All right, next slide. So just some key initiatives. We talked about workforce at some point, and there is a lot of investment. This 1.7 number actually was shifted downward, unfortunately, to 1.5 billion in the May revised budget, but most of these efforts are not being cut. I mentioned community health worker promotora effort, $350 million going there. I hope that we will find over the years to come that this workforce is connected to primary care, chronic disease, behavioral health, a huge social work initiative. We haven't had a social work initiative in this state. if ever, certainly for quite some time. There's nearly 100 million, I actually think it's 90 million for psych residency programs and other training programs specifically around behavioral health, the behavioral health workforce. And then, as we often talk about, the need for multilingual health workforce, another $60 million focused on supporting those from diverse communities to increase, with the goal of increasing language access and cultural competencies. So these are just a few of the efforts in the workforce area. I share them with you in hopes that there's a place for UCs or UCSF in helping promote and get these programs alive and well in our communities. Next slide. So I wanted to talk just very quickly, and then I'll wrap up, around youth mental health additional investments from this May revise. So there's 3 areas. We can go to the next slide and I'll just run through them quickly. So we put in an additional $290 million of one-time general fund into a few key programs, really focused on what we can do more urgently, emergently now. So investments in youth suicide prevention programs, recognizing that sort of the changing face of which young people are attempting and successfully committing suicide, focused on Black, Native, Hispanic, LGBTQ, and specifically foster youth. We've noticed through some really quick and important work of our child welfare service providers and advocates, just a real tick up in foster youth committing suicide, so some focused dollars there. $50 million likely going to schools and actually probably local public health and maybe behavioral health to work with schools and community-based programs on sort of a new approach to suicide and youth suicide, not just focused on the individual, their immediate family, but the friend group, the school. This will not be a required, if we do this, a required reportable public health event. It will be something that we hope over time, if it is reported in, that there is a more predictable sort of expected response to what happens, not just for the young person, but for the school or community at large. And so we're looking to pilot this with a handful, maybe 3 to 5 counties, depending on interest. Next slide. There's also $85 million that are going into grants for wellness and mindfulness in schools and in community entities. I won't go into the video series, although this builds on some work that we did with an institute called the Child Mind Institute to create some really high quality, good videos that if you haven't seen them, I'd love to share the link for you to watch those, that help both educators and parents sort of deal with the COVID reality. It's not COVID focused, but it's focused on the sort of post-pandemic or sort of the phase we're in now, with supports and tools to equip young people, families, and educators with those tools. Some additional workforce dollars. This one is interesting, I think timely and important, this assessment and intervention piece. We're investing $75 million into creating efforts around both understanding and unlocking the benefit of digital, social media, other technology supports in the realm of youth and child behavioral health, but also looking at how do we as California stay on the leading edge to make sure we understand how these different platforms, different tools are creating risks for young people, whether it's the metaverse and just the whole alternate reality world that is developing so quickly, or more standard social media platforms that certainly can wreak havoc for young people who don't have support in how to use those. And then this is also pretty important, I think directly relates to what you all are thinking through, $700 million in the January and May budget to work on practice transformation grants. And there's $100 million specifically around children's health focused areas, as well as dollars that are directly focused on behavioral health transformation. So this is meant for bread and butter practices in the Medicaid system who want to transform, integrate, do things differently in a number of different areas. So we hope that you all will consider how that can support some of the work that you're doing. Next slide. I know I'm running over a little bit. Cal Hope, I hope that you all are aware of Cal Hope, that it's going to be extended, it's growing, building. It's a real resource for people. You can, again, through these slides, get a little bit more information. And then next slide. So here are just in my thinking about how does this sort of support and help you. And the question that Anda asked me that I think is burning, and I'm really happy is burning for all of you, is how do we help the families, the young person in need who comes into clinic or is in urgent care or the ER, that we don't really have the tools to support. So, I think it's just evolving what it means to integrate behavioral health services in primary care. This isn't just, new protocols, new screening tools, but how do you, similar to what happened with Kemp Clinic or the asthma clinic at SFGH, how do you build those sort of multi-specialty opportunities for young people who are high risk or at risk or identified as young people with more serious and concerning behavioral health situations and conditions. So I think there's opportunities both through CalAIM, the transformation dollars, to, I think, really lean in and build that. I think that UC and UCSF can really support the training programs for expanding this behavioral health pool of professionals. There's new funding for nurse practitioners and social workers on top of residency training programs. Our Medicaid initiatives are all pushing partnerships with pre-K to 12 and higher ed. So how do you support and partner with your education, local education institutions, whether that's public schools or public higher ed, to really figure out how you interweave your services and work together. Once we have available the statewide e-consult, I think it's going to be important that we get the word out and pediatricians and others are using it. The Cal Hope service is available now. I hope you'll look into that. And then I think I'm going to skip to the very last one because she's a dear friend. I think she's a really amazing leader, Yolanda Richardson, who used to be the secretary at the Government Operations Agency for the state. She recently left to become the new CEO at San Francisco Health Plan. I think she would really enjoy and appreciate an opportunity to talk to all of you about what you're seeing as relates to Medicaid beneficiaries and young people, where you think opportunities are, and how all the state dollars that much of which is flowing through health plans can end up to supporting the tremendous work that all of you are trying to do and do more of. Next slide. I think that's it. I know it was a whirlwind. These things are always hard to sort of identify all of the excellent work at once, but there's a lot going on, and I hope we're doing it in a way that integrates it across not just health, but other sectors as well. And happy to either take questions or jump right into the panel, which I think is the plan.
Thank you so much, Mark, Secretary Ghaly. Lots of resources and opportunities you presented. There are a few questions in the chat that you might want to look at. I don't know if you or anyone on your team might be able to direct us to where some of the funding resources are. I don't know if they're all in that hub that you mentioned on that slide, but just you'll see that some people are asking where to find these funding opportunities. Thank you so much. We do have till 3 for the panel, and any one of these panelists, and if you can put up the slide of the discussion panel, could of course give their own talk, but we didn't have time for that. It'd be like a 3-day seminar, of course. I want to introduce Dr. Brian King, who will be moderating the panel. He's Vice Chair of UCSF Child and Adolescent Psychiatry. And the goal of the panel is to address what are specific and concrete ways healthcare team members can optimize their role within the mental health ecosystem, given the new and unprecedented state reform. So we'll be joined by Lisa Fortuna, who's Chief of Psychiatry and Vice Chair at ZSFG and UCSF. Melanie Moore, who's Chief Executive Officer at Oakland Thrives. Tom Insel, who's the former Director of the National Institute of Mental Health. And again, of course, Mark Ghaly and Alex Briscoe. So thank you all, and I'm going to turn it over to you, Brian.
Thanks, Onda, and thank you, everyone, for joining us today. It's really a wonderful opportunity for me to have a chance to take the panel out for a drive, and we'll start right in with the questions. I think Secretary Ghaly will hit you first while you're still all warmed up with a question that you sort of answered in a way, but one that that we were very eager to make sure was put on the table, which is how we as a healthcare system can be the absolute best partners to increase the impact of the investments that the state is making. We have over 100 panelists that are all saying, "Send me in, coach."
Yeah, I think it's a good question. And I would just say a couple of things, Brian, at a few different levels, right? So first, as direct service providers, there is the work that you're doing to both meet the needs of the individual in front of you. I think continuing to catalog and understand how to use the different tools available. I mentioned a handful. I know there are many more unique to San Francisco that just building those tools, integrating them more into common day, everyday use and practice, maybe even changing the model of how the clinic flows and works to integrate new types of workers. I think that's all exciting work that you all do already and can continue to do. I think UCSF is not just that. You do so much on the research front and pushing the evidence forward. I think in California, we are a big enough state where if you get enough UC partners together to push forward a good idea, we can develop the evidence quickly, get it on our radar, get it into the Medicaid system as a billable service over time, and really push the envelope in that way. So I plead and hope you all will continue to do that work. And then as a training institution, really building the kind of infrastructure we need to get not just the right number of Californians trained to do this work, but hopefully innovating on what that curricula looks like, how it is built and integrated here. And I went through a bunch of different funding sources that give you the opportunity to do some of those things. So you'll have to choose wisely, of course, because there's not energy to do it all. But I think there are just a number of different areas to be able to push the envelope as far as you can, and certainly something that will have impact beyond just your local community if we can scale it. So we tried to set up a lot of the investments at the state level so that partners exactly like UCSF can sort of come in and engage at a number of different places to help not just the person right in front of them, but over the long run and across the state.
Thank you. Thank you. I would want to turn to Dr. Lisa Fortuna for a follow-up related. Dr. Fortuna, from your vantage point on the front lines at the Zuckerberg San Francisco General, we're sort of in a be careful what you wish for scenario here with lots of opportunity that is being presented, and yet you don't have a workforce that's not already working to capacity. And so there's something needs to change. And I wonder if you have some thoughts about both how we can leverage this opportunity to address workforce challenges, and also if you could speak to not merely the increase in the number of new people coming into the field, but also how we retain a workforce that is burned out with the overwhelming pressure that's put on both primary care and mental health clinicians.
Okay, thank you. And can you hear me okay? I'm at the APA and the internet's acting a little weird, but I think it's going to be all right. So I think these opportunities, it's sort of, it's a little bit overwhelming because it's like, oh my God, we have to sort of get on these things, right? Because they're actually going to be able to transform our practice. And all of the things that we talked about today, I think has the opportunity to improve our expansion of our capacity to do services with the workforce that we have, as well as build an increased workforce, right? So I see a lot of improvement in capacity and efficiencies in some of these initiatives. So for example, if we can have more sort of support around integrated care, like on the behavioral health side, right? If we can actually sort of collaborate more and do more collaborative care with primary care and take off some of the weight of the pediatric workforce having to try to take care of these things by themselves, right? And we can actually extend our services, not just on the specialty side, but actually more collaborative, care that we can sort of support panels of children, right, in pediatric services, and take it from a population health perspective, right? Sort of how do we sort of support pediatricians taking care of groups of children with specific behavioral health needs. And if we can do that with schools, right, and sort of expand all the way back in terms of supporting the schools and supporting, I think that all of that helps us with burnout, because I think one of the main issues that at least I experience as a clinician, and I think others do, is sort of that, or sort of almost this moral injury, right, that we're experiencing in terms of not being able to take care of kids adequately. I see on the chat, which is true, 6-month wait lists, not being able to take care of all the needs of the children, that's happening on the pediatrics level, primary care level, and the specialty care level, right? So I think all of these things can be very helpful. The other thing I want to point out, and then I'll end, is this other workforce, these navigators, these promotoras, these other, people who can support our work. I think is super critical as well, because I think some of the things that we all struggle with is how to navigate our patients to the different services they need in the community. What happens to them when we refer them, right? What's happening with them in the community? And so I think that builds our work to be more efficient and helpful for families, which I think also helps burnout.
Thanks. I want to go over to you, Alex Briscoe, next. You, and this is sort of related in terms of be careful what you wish for. So it's really thrilling to see that the medical necessity criteria are no longer going to get in the way of our ability to provide care for people that clearly need it. But one of the things that those medical necessity criteria, so it was never our idea, but those seem to have been put in place to essentially limit access, reduce the costs on the system. And there are other things that have been inserted as well in terms of the documentation burden that's required to demonstrate that we're doing something legitimate in the provision of service at every level. How do we ensure that with the removal of the medical necessity criterion, that something else won't move into its place to constrain access in the absence of the funding that you mentioned.
I love this question, Brian. Removal of diagnosis or the reforms of medical necessity is a symbolic victory. It is meant as much to change the culture of the healthcare industry as it is to expand access to care. It will mean nothing unless you change what you do and learn how to get paid for it. So and I can say this as an advocate, and I will offer this as an admission, as a nudge to both the state and to the systems like UCSF. You have to change what you do, and you have to learn how to get paid more for it. So I would invite you as a system. I can say, having now worked around your system, Brian, we discovered there were tons of providers not credentialed, not dropping bills. Like, embrace the complexity and hustle as hard for revenue as poor people do for rent. That's actually something that Vanna Chavez told me, the finance director for the county health department. I think the entrepreneurial spirit and focus to understand the flow of financing has to get real specific and pretty rigid. And I don't think UCSF has the right culture. I'm just going to say that. I think it needs to be more aggressive, more detailed, and more specific in terms of your internal controls. But then externally, I think you need to be more demanding. I think you need to say to your payers, no, this is the right documentation standard, meaning, and here's the nudge I will say again, and I hate to be so mean, but the critique is not the strategy. As you know, I'm married to one of your clinicians, and wringing your hands at the problem isn't the same as saying, no, this is what the documentation should be, carrying that to Secretary Ghaly and saying, what is being asked of us by the payers is not appropriate. We're a provider, make it like this. So I would say sharpen your internal controls with the tools at your disposal, and then sharpen your external advocacy to a level of specificity and redesign and construct the system that you want to work in. Can't help but do it, but I'll say to Secretary Ghaly, we have to be better, or the state has to be better at clarifying the system that remains bifurcated and who gets what, when, and where. The reality is that these systems remain confusing and difficult to navigate as health systems. And while the new resources are welcome, I think more clarity is needed on the future footprint of Medicaid and where the counties play and where the MCOs play.
Thanks, Alex. You mentioned innovation, and that's something that I want to carry over to Dr. Thomas Insel as a question. In the last session, there were a couple of references to the mental health care system sort of resembling the Winchester Mystery House, with various add-ons over years and years, all of them beautiful but not connected, and in some ways following up on what Alex has shared. One could even question whether there were deliberate attempts to keep things from being navigable. But another way to look at it might be as like the transportation system, where we have big highways that get us places, but other forms of transportation are required for any individual to get to their destination. And while we had loads of cabs in our system forever, Uber entered onto the scene recently, and it has had an enormous impact on how people get from place to place. Where's the opportunity? What do we need to be thinking as we're looking at our challenges here with respect to bringing in innovators? As someone who has transitioned to being an innovator yourself.
Well, at least an entrepreneur. Yeah, thanks, Brian. Actually, listening to this conversation, I was thinking how we haven't heard a lot about that, which is odd. A long time ago, somebody told me a story about T.S. Eliot, who was both a great poet and actually a pretty serious banker. And T.S. Eliot used to say that when he'd go to lunch with bankers, they talk about poetry. When he'd go to lunch with poets, they only talk about money. And sometimes it feels like we're in that space here where all of us want to be helping kids, but mostly what we're focusing on is money and how to get paid. I understand that. And Alex is absolutely right that because what we're talking about is a health system, which at the end of the day is a business. It's an industry. And if you want to understand how it works, you have to follow the money. And that's unfortunate, but I think it's unfortunately true. So what we ought to think about, or what I hope we can talk about a little bit, is where the opportunities are to bring in some innovation. And there's an enormous investment in that. I mean, a $4.4 billion youth behavioral health initiative is historic and remarkable. But just as a point of context, we spent $5.1 billion last year in venture capital money just in digital mental health startups and trying to innovate the way that mental health care is delivered. And it is, I think, being totally transformed. We're still at the beginning, and I'm not sure much of it has really had much of an impact on kids, particularly kids of color. We have a long way to go for large parts of the population. But I guess I'd say two things. One is, let's invite in the people who are thinking about how to do this more efficiently, how to do this in a way that actually can start to solve some of the problems, as Alex was just saying. So we're not just wringing our hands, but thinking about, in a world in which so many ways of changing the way we deliver goods and services has been transformed by AI and by technology, why aren't we talking about that for kids' mental health as well? And what would that look like? And I'm not even sure, but it does seem to me that it's a conversation worth having. And it's probably a conversation that begins with identifying the big pain points and trying to figure out with really smart innovators what could be done. The second thing I'd say, and maybe it's obvious to people, but it wasn't obvious to me, is that I think one of the things we can learn from technology, and really the technology industry, if you will, is it's not the products, it's not the apps, it's not the software, it's not like all the cool gadgets. It's the culture, which is probably different than the culture most of us think about. It's certainly very different than the culture we work in. The three things about the tech culture, which you learn if you work at a company like Google on the inside, and that is that they're very, very good at three things that we really are not very good at. One is engagement. They are so good at that, they are dangerous. They know how to get the attention of kids in a way that we just have not figured out. And we need to learn from that. We need to understand how they do UX, how they do user design, how they build for consumers, how they build with consumers, and understand everything about what makes a product sticky. How do you deliver something that people not just like, but they love? We don't do that. We really don't do that. Second thing they're really good at is quality control. So they think all the time about how to collect data in real time to get feedback about what we're doing working or not. And they just continually, when I was at Google working with the search team, at any given moment, we were doing 120 experiments, sometimes with 10 million people before lunch, right? And all that data quickly goes into an engine that changes what you do in the next hour. So it's better than it was in the previous hour. And that's how they've succeeded to become such ridiculously successful, arguably dangerous companies. The third thing they do, which I think we need to really get serious about, Alex mentioned this before, is they build in accountability at a level that we don't really experience. They pay for performance. That you get paid, when you work for a company like Facebook or Google, actually your salary isn't that great. Your compensation can be huge, and it's 70% of that is based on how you perform. It's all in the bonus. And that's a symbol in a sense. It's not particularly important for this conversation, but the idea that you hold people to standards and to outcomes, you set what they call OKRs, objectives and key results, and everything is managed according to those OKRs on a quarterly, sometimes monthly basis. And if you hit those OKRs, you get paid. If you get beyond them, you get a bonus. If you don't make it, you get fired. We don't talk, we don't think, we don't act that way. We don't hold ourselves accountable for outcomes. In fact, I'm really interested because I think what Mark presented is absolutely historic. It's like the most significant investment I've ever seen in my entire career for youth behavioral health. The magnitude, the scope is phenomenal. And we should all be incredibly grateful for his leadership on this. But I think now what we're going to ask is, how do we hold ourselves accountable for actually delivering on this promise? What are those small group of outcomes that we're going to drive towards in each of those areas? Because there are like 10 different places that we're going to be totally changing the way we deliver kids' mental health care. And actually not just care, but what we're doing about kids' mental health. So what are the things that we're really driving to? And how do we reward ourselves if we get there? And how do we hold ourselves accountable if we don't? So I'd love to sort of bring that culture of tech into the way we talk about transforming mental health in California. I don't think that's happened yet. And I think the time has come to really get serious about engagement, quality, accountability.
Thank you. Melanie Moore, Oakland Thrives did a environmental scan of the mental health landscape in Oakland. And I wonder if you, thank you for doing that. And I wonder if you could share a little bit about what the top drawer findings are in terms of how they might inform some of the specific targets that we should be aiming at.
Thanks so much, Brian. I dropped the report in the chat so people can have access to it. And of course, we can include it in any follow-up that we send out after this session. You know, the saying, luck is when preparation meets opportunity. I am really glad that about a year ago, in part owing to Dr. Dana Long's leadership and other leaders from Oakland and Alameda County and Oakland Unified School District, Oakland Thrives, which is a joint powers authority that is a collective impact effort in City of Oakland to support the needs of children, youth, and families. We named child and adolescent mental health as a #1 priority. And we knew the first thing we needed to do was conduct a landscape analysis to figure out what resources do we have and where are the gaps. And this was all kind of simultaneous while you know, these incredible leaders that we're hearing from at the state were architecting these opportunities. We were assessing how prepared we were. And I think we're fortunate in Oakland and Alameda County, we have a lot of infrastructure ready to go. We have school-based health centers. Oakland Unified School District has led the state in the creation of community schools at every level of schooling. We have amazing nonprofit organizations that think about sort of the surround sound of mental wellness, whether it's Attitudinal Healing Connection in West Oakland, or we have federally qualified health centers like Native American Health Center that are thinking about culturally congruent models of mental wellness and mental health care. So we have an amazing infrastructure. And I'd say one of the key findings is, not surprising, that we're not all aligned. Everybody's doing good work or even great work in their silo with a relatively small number of patients or clients. And if we could talk with each other more, if we planned with each other better, we could really start to scale the impact of the work. So that was one key finding. But specifically with regard to, you know, at the most local level, how do you take some of these funding streams and bring them to the ground? How do you get that last mile? We figured that there are a couple of big buckets of work that are only going to happen if we really roll up our sleeves and think outside of institutions and cross sector. And the first big recommendation, which we've already voiced today, is that we have to increase access to clinical care. And a key part of that is through expanding the workforce pipelines from high school on up. And those pipelines have to be aimed at licensure, so, you know, clinical professionals, but we have to broaden the pipeline to think about non-clinical licensed caregivers, who are those community health workers, who are those violence interrupters in the neighborhood, who are the restorative justice workers at the schools. So that's something we can do on the local level. And we can do that by talking to our workforce development boards, our local colleges and universities, our incredible programs like Jessica Pitt's wonderful program in Alameda Health System, you know, Health Path that's already thinking about how to get young people into health careers. But we have to also, as we're being coached to do, draw down the funding to support the development of those workforce pipeline programs. These programs don't happen just because the state puts out the RFP. We have to get nitty gritty, roll up the sleeves and figure out who's doing what, guys. The devil's in the details here. Who's going to do this, responsible for this part of Oakland, or, okay, Alameda County, what's your role? And the purpose of a collective impact table like ours is to help kind of navigate that traffic, sort of be the air traffic control. So second major finding is that we have to wildly proliferate non-clinical care and non-clinical wellness promotion for children, youth, and families in all of the settings where they experience any type of sort of, environmental exposure. So at the grocery store, at the library, yes, at the community center, at the park, at the school. And if you want to think about the way that a system like UCSF can relate to that type of broad community effort, think about efforts in early childhood around talk, read, sing. Think about how pediatricians have been brought into developmental screening in Alameda County and other counties through Help Me Grow. Our first 5 commissions are really bringing an awareness of holistic development into pediatric practice, providing concrete tools for pediatricians to do that. Think about the fact that, when you go to your well child visit, you can get a book, you get handed a book when you walk away. So you were connecting literacy with health provision. So we can do that with mental health as well. And it is through practices like mindfulness. It is through ideas such as, addressing structural racism, creating safe spaces where young people can talk with each other about their experiences of implicit bias. All of these are non-medical interventions that are supportive of mental health care in ways that will dramatically amplify what we're able to provide through clinical settings. So with those 2 big buckets of increased access to clinical care through workforce and expand dramatically the opportunities to promote mental wellness in community, we're trying to bring providers together to draw down some of these funds. But Oakland Thrives is, we're stone soup. We have the big bucket of water in the rock. You guys have to bring the vegetables and the salt and all of those good things. And we will keep that fire burning and figure out how we can, maximize the resources coming to our geography. But it really takes all of us.
Thank you. One of the non-clinical elements potentially for the soup was highlighted in an article in today's Chronicle that talks about a $70 million investment in schools to bring back art programs and music programs and dance and sports and things that could clearly be helpful. I saw in the report that some kids specifically highlighted art and music and other things as their de-stressors. I wonder if there's another opportunity to add to the mix through investments in these kinds of areas.
Brian, there are a few questions in the chat that I thought I might just throw out there, and then you can put it into the mix of other questions you might have accumulated. But there are 2 of them. Well, some of them are basically about common barriers in implementing these opportunities. One is there a way to get policy changes to allow for longer visits, for example, using dyadic benefit or the Z codes? And the other was around, with the network of care and the care coordination elements, privacy rules and policies and ability to communicate with our partners. And if anyone has any thoughts about those, but I don't know what other priority questions you have. So just throwing that in the mix.
Well, let's pick up on both of those. I think maybe Alex, are you?
Yeah, sorry, Brian. I was going back to your previous comment. Like in the emerging reform landscape of Medicaid, managed care plans are really, really important. Like we are driving a lot of the reforms through them. They have historically not contracted with anybody but traditional clinical systems. And your prompt was, how do we pay for other stuff that we know young people need? Or how do we account for the trust and alliance that is necessary to connect with young people? Like I can remember saying what's up to a kid for 4 years every day before learning he slept in a car. Mm-hmm. Like health plans don't pay for that. They don't pay for texting. Like they don't pay for all the stuff that it takes for a clinical class that doesn't look like the kids that we're trying to serve, to build that trust and alliance that is such a necessary precursor. So managed care plans contracting with non-traditional actors, it's beginning with ECM. So to be fair, there's some movement there, but that is like an essential. To get paid by a plan means you have to get paneled and credentialed with them.
Mm-hmm.
You guys struggle with it, and you're UCSF. How is a culturally concordant CBO going to come under contract to a plan and become part of a treatment team? I think that issue of building the bridge between the non-traditional social and emotional support actor, the culturally concordant CBO, and the payment system of Medicaid is a challenge that we have not effectively overcome.
Hey, Alex, doesn't CalAIM really get us a long way towards that, particularly because it's now shifting so much of the care into MCOs and it's holding MCOs feet to the fire for creating what looks like capitated care. It looks like almost value-based care. Isn't that going to do a lot of this almost de facto?
I push that to Mark. What I would say is that I know of very few, if any, small culturally concordant CBOs who even know what the Medi-Cal managed care landscape is in the communities they serve.
So I would say that this is a huge challenge because we haven't done this before, but I think the substrate to start doing it is absolutely there. It's not just in CalAIM, not just sort of supported through the enhanced care management concept, but PATH funding. So PATH is kind of the on-ramp program, if you will, into a lot of the CalAIM work. This is a bucket of dollars that are going out immediately to support different levels of service providers to both figure out the relationship with Medi-Cal managed care plans as well as build their capacity. So there's an opportunity there. The sort of the whole notion of CalAIM and creating the connections to whether it's in the homeless service provider space or the behavioral health space, there's the substrate to see that build up. And then the thing I alluded to, but we certainly haven't talked a whole lot about, and we end up giving a lot of attention to CalAIM, but I would say the main event in Medicaid, by far, not even close, isn't CalAIM, it's the Medi-Cal reprocurement, which is really redesigning all of those expectations on plans. And there are clear issues around accountability that aren't there today. This is a 500-page document. If anybody wants to see the link to it, you should. It's a doozy to read, but it has in it a bunch of sections that push the envelope on what are we expecting out of plans in terms of the relationships with schools, community-based providers, not just health systems, not just public health systems, but a whole array of providers. What are we expecting in terms of achievement around value-based care metrics? What does the transparency look like? And what are the consequences if you don't meet some of those needs? So this is our first real push to make the system, in a way, raise all boats, not just in specific ways. It is crafted with a unique sort of approach to ensure that CalAIM is built in, but it's really that's going to drive the next 5 to 10 years of transformation in Medicaid. And so CalAIM, or the next version of a waiver, will all get deeply embedded into the contract language the state has with the plans, because Alex is right. We are depending on plans more and more to do this work. And that's why I think your conversation with somebody like Yolanda Richardson is vital to understand how are they going to implement this? How are they going to lean on you and other community partners to actually get the work done?
Thanks. Anda, it looks like we are coming to the end of our time. I have one more isn't it true question that I wanted to be sure and throw in there today. And actually, this one's for you. Isn't it true, Dr. Kuo, that we have been so fortunate to have an amazing panel of leaders join us today and can't thank them enough?
That is 100% true.
So, so back to you.
Thank you. Just to honor everyone's time, I know we could talk on and on, because if this is an easy problem to solve, we would have done it with so many bright and innovative leaders in place. But we are, I have faith that we are going to crack part of this nut and make things better as a system together. I really appreciate the leadership and the time people have taken today. We're due for a break. Our brains are probably hurting and our stomachs are grumbling, so we have a 10-minute break. This is where, but don't leave just because our fabulous panelists might have to slide off or will be off camera, because this is really where it matters. We brought people together to try and digest some of this complicated information and see where opportunities are. And so in our breakouts, we'll have a chance to talk with each other and really try and figure out, given what we've heard and what we already know, where can we start putting some action steps next, and that will also feed into session 3. So we have a 10-minute break. Thank you so much, everybody, and come on back, please. Come back, everybody. I'm looking for my colleague, Dana. There you are, Dana.
Hi. Hello.
Take it away.
Thank you. Can I tell you guys, I'm just like so blown away by the conversation that we had up to this point, and honestly, what it means for us as a health system. I mean, the fact that discrimination and racism is now qualifies for mental health services. You have to understand that for those of us that work in safety nets or are ourselves people of color, like that's actually huge. So that the profoundness of that is sitting with me. And right now we're going to have the opportunity to talk about all of the great information that was just shared. We now have this better understanding around state funding and policy reform, and really opportunities for us as a healthcare system to optimize the care needs of our patients and community that have mental health concerns. So we need to better understand how we are putting the pieces together on a more granular level, how we're taking the high level concepts and actually putting them into action, what we need to do, what steps we need to take in order to have change. So we have 3 breakout rooms with local healthcare leaders and representatives, and we're going to have a discussion. You can see that there is a San Francisco County group, an Alameda County group, and a UCSF Benioff Children's Hospital group. You can select the group that you want to be in. Each room is going to have a facilitator and a note taker who will provide further instructions on the questions that the groups are going to discuss. We have until about 3:45 for the breakout rooms, and then we're going to come together for a larger discussion, and then we're going to close out our day. So Cassandra is putting information in the chat about how to select your breakout room, and I'm really excited for the conversation to continue. Thank you.
So I think you just find your name and it'll say assigned to, and you can click whichever, when you click on that, it'll tell you, give you options for rooms.
Thank you, Andra. We can also go ahead and assign people if it doesn't look like they've moved yet.
And this is Francine, and if you could assign me to UCSF.
Hi, Francine. I'll add you to the right group.
Thank you.
And if someone can add me also, this is Kamisi. I was logged in through my phone, so I just now did the computer because I realized I couldn't access anything.
Where do you want to go?
Just a second. Someone assigned me via email. Why is this doing that? I'm
Dorothy,
sorry.
I'll assign her to the Alameda County group.
Yes, thank you.
Hey, welcome back, everybody. And we had such a great discussion in our breakout group. I hope everyone else did as well. And appreciate all the expertise that people are bringing. We didn't want to do the traditional large group share out and summarize what you heard, because we will be summarizing it all and sending them out in notes and to follow up. But we thought we could end here to set us up for the third session. And I've already heard some ideas in our small group breakout about who we could bring into this conversation to really reimagine what this could look like. It probably came up in your groups as well, but we wanted to pose the question so that we have some ideas for the session 3 as we move from promise to practice and create the roadmap for the future. So given your conversation in the breakout groups, what is one important thing to consider or that you'd like to happen as we structure the third session scheduled for June 28th? And I hope you all will be able to join us. So please share in the chat or unmute yourself. And we also have a very brief, I think it's like 2 or 3 questions as a QR code there in the bottom right. And also in the chat. Thanks, Cassandra. Any thoughts? While I'm waiting, I will share, like, I did hear from our group ideas of like bringing in, we have our partners, the schools, patient voices. So I can already imagine bringing that in. And we did structure this series in response to the desperate just feeling our providers on the ground were feeling about the large wave of mental health needs and our inability is not the right word, capacity, I guess, to provide the care we wanted to provide. And that was the genesis of this. And of course, it's going to include, as we think about the solution and how to reimagine, of course, all the different aspects of children's lives and where they live and spend time come in. So yeah, how to best support CBOs with capacity building, financing, contracts, et cetera. Is that you, Dana?
No, but I was going to say that one of the really important comments that was made by Melanie in our group is, as these opportunities come up, how do we create partnerships, and who is the holder of the opportunities who can make sure that we're inclusive and that we are actually able to deliver on the opportunities in a way that best benefits our children and families, and that it might not be in each individual CBO or UCSF, but rather, as an example, sort of Oakland Thrives, which is this collective of leaders who represent many of our CBOs, who can be the holder of the grants, of the opportunities, and make sure that everyone's included in that process. And I think as other counties start to consider these RFPs, how do they make sure that they maximize on them?
And while we're waiting, I also just want to lift up, during this time, I got to step out Castlemont Health Equity Academy, which is one of the pathways at Castlemont. The young people were demonstrating their ideas and their work that they created over this last semester. And it just filled my heart so much hope that, like, the young people have the answers, the community have the answers, and what our job is to bring these resources down to communities, to families, to children. But to see this Health Equity Academy at Castlemont really showing their ideas, just gave me so much hope. So I just wanted to share that with this community.
Thank you so much for sharing that. That is really nice to hear.
And
other thoughts? There's some great thoughts in the chat. Go ahead, Joanne.
One of the things I think that emerged as a theme in our breakout room, I think was partially alluded to in the chat, kind of collaborating across our own internal silos to kind of maybe go after some of these grants or opportunities together, because it's very easy for us to just become competitors with each other. But instead, like, can we actually like pull together and figure out ways that we could collaborate? And like even find out what each other are doing and disseminate best practices internally and disseminate some of the knowledge that we heard today, like internally. That seems to be some low-hanging fruit there. You know, sharing, like, making some of this information digestible and accessible, and just sending it out, and then creating some kind of space for us to be talking further and brainstorming together, you know, beyond like our 30-minute breakout session as to, and I think that's part of what we're going to be building into our next session anyway.
Thank you,
Joanna. I appreciate those comments so much. And also, Dana, just the nod to collective impact as a model. That's road tested. I mean, Oakland Thrives is not the only collective impact entity in the country. There's a whole network nationally of groups that really are trying to be that honest broker of collaborative work in a jurisdiction or across jurisdictions in a place. And part of what we can also do, I think, in that regard together is back to what Tom Insel was saying about building accountability frameworks that are similar to the sort of rapid feedback loops that we see in the innovation spaces, because we typically in the government sector and in the nonprofit sector, even in the hospital sector, you know, we create incredible initiatives and we're slow to figure out if they're actually working and having an impact. And we need to get much better at that. So as we apply for all of these RFPs, we're going to be required, I'm sure, to have accountability frameworks that are written in. If we can think about those accountability frameworks at a population health level, rather than at, you know, the particular, you know, 100 people that we know are going to come through the doors every month, then I think we really start to think at a systems level about integrated care coordination, about how does the young person experience care from, you know, elementary school to middle school to high school, and what's the experience of the parents. So I would encourage us to collaborate around the funding and really think at the population level about how are we creating impact with the opportunities that we have as systems to work together.
Others, we have a few more minutes, maybe one or two. So far, there's a lot that's been shared. What's coalescing is the opportunity between school health partnerships and really integrating and care coordination between schools and healthcare for children and adolescents. Also integrated behavioral health and not just like it's helping each other figure out how to crack the nut so we can do that in a sustainable way and help the CBOs figure out how they meet Medicaid providers and whether there's partnerships there, and also the value of collective impact and really nourishing the partnerships so we can do things jointly and work together. Any other last parting thoughts before I toss it over to you, Dana? All right. You want to close this out, Dana?
I do. So we all know that if we're going to be part of the solution, we have to engage in the problems. We have an immense problem on our hands, and I'm so thankful that all of the leaders and on this Zoom are willing to roll up our sleeves and really engage in tackling the problem. So thank you to all the speakers and participants for attending our second session. We will post recordings on our website, and we are going to summarize all of the findings today, including the notes from the breakout rooms, and we're going to share this at our next session. So session 3 is going to happen on June 28th, and session 3 is about moving from promise to practice, a roadmap for the future. We're going to consolidate what we've heard from our great providers and policymakers and system leaders and advocates to create a shared roadmap to improve the mental and behavioral health and well-being of our children and families. The speakers for our next session will include the president of UCSF Benioff Children's Hospital Oakland, Matt Cook, the VP of Ambulatory, George Weiss, our chair of the Department of Pediatrics, Raphael Hirsch, and you'll hear again from Brian King, who's the vice chair of UCSF Child and Adolescent Psychiatry. So thank you so much for your participation, and we look forward to continuing the conversation to actually get all of these ideas down on paper onto our roadmap. You're going to see a couple of things in the chat from Cassandra, and that includes our event page and the recordings with the registration link for our next session. There also is an evaluation link. So thank you very much.
I just wanted to add quickly, like, if you think that we've got it here, we have a huge production team where it's like a bunch of us volunteering twice a week to plan this out. So don't assume we know the person to invite, or if you're thinking like, why didn't they invite? Please send us an email and connect us. And we would love to like bring, I remember last session, there was a comment in somewhere in the evaluation or something where they said, you know, we want to see people we're not expecting at one of these sessions. So please send us those people that you may not be expecting. We want to be inclusive. And I just want to really shout out to Cassandra Vega, who's been so instrumental in pulling this together. It's just blood, sweat, and tears. And I know at the end of this, it's the most like emotional for us because it's like, it's been a lot to pull together, but we just are so grateful for what's happening here. So thank you all for engaging with us. Thank you, Cassandra, and thank you to the planning team. Have a wonderful day. One of the trauma-informed practices is to end on time, and we're actually giving you a little time back. Go enjoy.